Welcome to the Hell 210 podcast. Today we've got a physician who's also a full-time footballer. This is Dr. Medrano. Welcome to the podcast.
Well, thanks for having me.
Absolutely. How are you doing?
Great. Happy to be here.
Excellent. Lovely. So there's a lot of things to talk about, much of which is obesity related, but I want to start from the start. So I understand you're from Chihuahua, Mexico.
Right.
Tell me a little bit about the story. Tell me how things started, how you got to the States, and everything in between.
Well, to begin with, I always knew I wanted to do surgery.
Okay.
And going to med school was kind of like my hurdle to get through.
Yeah.
I was lucky to have one of my close uncles as a surgeon, and he would invite me to the OR when I was 12.
Oh boy.
I remember almost
early start.
early start. So the first time I went to the OR and the smell of the cautery and stuff, I was like dizzy. I was discouraged. I thought like, this is not gonna be my thing. And he told me, he's one of those people that you look up and say, I wanna be that as a person.
Sure.
Not only like he's the best surgeon ever.
Yeah.
And
he was an inspiration.
He was very inspirational. And he told me, because he was a big name back home. That was kind of like why I was inclined to follow him. But he said, don't worry, this happened to me actually. Probably didn't, but he was probably trying to make me feel better.
You.
And it happened to me, don't worry, this doesn't define what is it that you want to do. And then I kept coming, and one of the first surgeries I attended once I was in medical school was my father. My uncle did a sleeve on my own dad.
Oh boy.
And I went to surgery. I wasn't thinking about bariatrics back then.
Yeah.
But I was just like focused on being there.
Wow.
So then I went to med school. Most of my med school was in Monterrey, in a different city, close to Antonio. And my goal was to come to the States because I thought the best training,
the best of intervention
would have been here. Yeah, absolutely. The most up to date and so on. And the model of training was also known to be great. So I did my best to be the best student I could be. I was able to get a grant. So I was able to go to Baylor in Houston to do research as part of my medical diploma. So in Mexico, fantastic. You gotta do a year of social service, kind of like get back to the community. And most people go to a tiny town, middle of nowhere, 2,000 people.
I'm a foreign graduate. It's incredibly hard to get things like that. So that's phenomenal that you got that.
So I was lucky, and I was even getting paid for that.
Oh, wow.
So, I spent a couple of years in Baylor and the Methodist Hospital in Houston. I did everything you can imagine. I was doing genetic testing. I was actually doing a lot of cardiac studies in mice. I was doing the ultrasounds and operating on the mice. I was doing a lot of like surgical, radiology, medical, all this kind of crazy stuff to build my curriculum to actually get into the States. And
this is all as a medical student? On the elective?
Once I finished medical training, the requirement was that. So I completed my requirement to get my degree. And so it was like, killing too many birds with one stone.
Oh, yeah.
And, I built up relationships, got my letters and everything. And I was doing my steps, my revalidation test, the USMLEs. And, I was lucky to be the only one out of 200 foreign medical graduates to actually get into surgery on their first attempt.
Oh, that's phenomenal.
For a categorical position. Like so it was 0.5%.
Yeah. Because we see that. I was in academics before. I was a foreign graduate. Matching into general surgery is incredibly hard as is. Matching categorical is even harder. And so that's great work. I mean, that I'm sure you have to be one of the top candidates for you to get that opportunity. So that's incredible. You said something like, I always wanted to be a surgeon. That sounds like a really strong statement to me. So how is that possible to always want to be a surgeon? It must have been something, I don't know, was it, so I get the uncle, but was there something else that sort of triggered that thought that you want to do surgery, or was it just the family that you saw around you?
So I think a lot of different pieces like focus and like converge in the concept of surgeon. So
Sure.
I love doing, crafty things or sitting down, like, video games, anything. Like I'm focusing on like eye hand coordination. Like that's,
Yeah,
I
that's
really,
that gives
that's
you a
my,
kick.
that's my zen. And when, in these experiences with my uncle, I kind of say, oh, I mean, this is something that, kind of like converges that. And I had some experiences with him, the way he was, he was a great example. He's about to retire, so
Yeah.
like I don't know, he's probably gonna retire like next year. But there was, in Mexico, it's not like you're always like super specialized. So he got to see like kids and oncology cases, and there was this, I don't know, he was probably like 7, and he had. He had some sort of colon cancer at a very young age,
Sure.
and he was, really sick. And he, we went to see him, and he told me, he's stage 4. He doesn't have much prognosis and stuff. He said, but we gotta do whatever we can. So he was talking about giving him a port and for his chemotherapy, and the kid, he had already interacted with him, and the kid was happy to see him, even though, as a kid, you kind of like associate pain. Like he already had
With the
taken.
physician.
Yeah, he, instead of being scared, he was approaching him, and I was like, "What's going on with this interaction?" And he was never like a foolish guy who's playing with the kid.
Yeah.
He was like very professional. He respected, and he was very clear, but in a warm way.
Yeah.
And very humane. And I was like, "Gosh, I gotta be like this guy,"
Yeah,
basically.
love
And it was kind of like there's a way in which maybe you're not able to cure, but you're able to help somehow.
Oh yeah.
And I also like kind of like fast type of results. So surgery is one of those things, like you do this, you take this out, you're done. It's kind of like, so there's
measurable results. All done with hands. You see bad, you fix bad, you leave good.
Yeah, it's very pragmatic. Yes,
lovely.
no, that's it.
So surgery, you decided you wanted to do surgery. You worked hard. You were one of the best in your school. You got in. In a very competitive situation, you got in. After the surgical residency, then you go into specialization, and you're specialized in bariatrics and robotic interventions. What sort of drove you towards that? What was the reason to consider, bariatrics?
So where I trained was a big trauma center, and I was able to do all this crazy, intense surgeries because the bullets go anywhere they want.
Sure.
So you end up like seeing anatomy very clearly, and you get comfortable to be in places that most people are not, because they're doing the more routine stuff.
Sure.
But at the same time, the downside is I didn't get much exposure to robotic surgery, which to me was, I need to do this in order for me to offer people better options, because I'm not gonna just operate on people that get shot and things like that, right?
Yeah, absolutely.
So one of the options was bariatric surgery, and there was this, I had a struggle whether I do thoracic or bariatrics, and to make the story short, bariatrics ended up being the pathway that I ended up taking. And at the end of the day, the obesity as a disease on its own, which is kind of like underappreciated.
Absolutely.
It's actually kind of like the mother of all the bad things that happen to us. So diabetes, high blood pressure, cancers. There's so many bad things we don't account for, and we just think about, my neighbor, has obesity. Well, not even that's how they say, right? It's like technically it's has obesity as you have the disease, right?
Yeah.
It's not like you are cancerous, you have cancer, right? Same with obesity. And it's overlooked and underappreciated, but it's, if you account into what kills people the most, is obesity. It's just you do the breakdown, right?
Yeah, you look at the impact, you look at the chronic disease impact that it starts to bring in, and it's up there, and there's no second. The second is so far below in terms of the prevalence and the impact globally. And especially in the States, I mean, when we talk about this, we're sitting in San Antonio, right? And we're known for, large meals and, just being generally overweight. In fact, I think San Antonio probably ranks
25th. It's the 25th largest, most obese city in the States. And McAllen, the Valley area is number one.
Number one, absolutely. So I feel like you did this right at that time where a lot of the newer things happened around obesity as well. So you've sort of come into bariatrics with sort of the start of this era with the GLPs, right? Tell me a little bit about that. So now in fact, before we dive deeper into that, as a bariatric surgeon, for someone who's watching, right, and they're not familiar with this, tell me first what does a bariatric surgeon do? So we talked about obesity. What is it that you do to fix that or help with that?
So I do want to just make a quick point.
Sure.
The actual bariatric fellowship program is something fairly recent. Before my time, people were trained on what is called minimal invasive surgery, which basically means you're skilled enough to do surgeries that are more complex through small holes, laparoscopically or robotically. But when it comes to the concept of bariatric surgery, it is not, I make your stomach smaller, you lose weight.
Sure.
Although the end result tends to be, very summarized, very simplified, that's the way. What happens is actually there is a hormone/metabolic dysregulation.
Absolutely. Yeah.
And as an effect of the surgery, that's what you end up modifying. So yes, altering the GI tract results in hormonal changes. Those hormonal changes, are actually the basis of the new medications, the GLP-1. So thanks to the surgeries, we understood more what happened to the body. And then these GLP-1s ended up being, like another tool we can actually use to help people further lose weight.
Makes sense.
Or as an alternative if they don't actually qualify for weight loss surgery.
So as a bariatric surgeon, you're doing procedures that modify the GI tract. You mentioned to be able to, one, of course, make the gut smaller, but it's not really making the gut smaller that's doing all the work. It's the work that happens with the hormonal side, the physiological side, and that's what's adding. So there's the cosmetic side of losing weight, but then there's the whole side of life expectancy.
Correct.
Living disease-free, not getting cancers, all of that. So diabetes, high blood pressure, sleep apnea, all of those things. Yeah. So what you're modifying is, it's not a cosmetic procedure. It is basically a life-altering procedure, and it prolongs a healthy life.
Yeah.
So you do your fellowship. You started with that procedure. Seems like you got to San Antonio partly because your spouse matched into a palliative care program. You mentioned that. And then you started your program at the Methodist Hospital. Tell me a little bit about your program. So what are the scope of interventions you all do, surgical and non-surgical?
So we do, in terms of the surgical side, the common ones, which are the sleeve and the bypass. The LAPAN should be something that is outdated, shouldn't be done anymore. There's other stuff like the balloon. It doesn't last long. People just regain the weight, so that should also not be done. And I specialize in a third procedure called the duodenal switch that is meant for people that have a higher degree of obesity or uncontrolled diabetes, because at 2 years, 99% of people have control or diabetes without medication. Wow. So it's it's basically life-changing, but it's only worth it if you are sick enough basically to merit it, because you can do better or the same with the other surgeries if you are a proper candidate for the sleeve or the bypass. Going back to a point you mentioned about the cosmetic part. So yes, people think weight loss surgery is a cosmetic thing. They don't see it as a needed treatment. Absolutely. And I get patients coming to the office and saying, it's too extreme. And I say, well, let's change the name of your disease. If instead of obesity you had cancer, is surgery for your cancer extreme? Or would you say it's appropriate? Also, is it the easy way? And I'll say, yes, please give me the easy way out of you give me my easy way out of my death, let's say. Yeah. So it's just the focus people have on it. And then the cosmetic part, it is in a way cosmetic, because there's a difference between beauty and attractiveness. Beauty is something that is very subjective, it's very individual. But attractiveness has more to do with the actual ability to bear a child or to have offspring.
Sure.
And that has to do with health. Absolutely. So you can be very ugly appearing, but they're very attractive. So when you are at a healthy weight, you are healthier, you're more likely to be able to have healthy kids, and you yourself be okay and withstand, let's say the pregnancy or get somebody pregnant, let's say. And that's part of the subconscious part of the cosmetic aspect of weight loss, because the cosmetic actually follows the health part. So yeah, it's just a huge spectrum. It covers so many things together.
I couldn't agree more. I mean, you get a diseased gallbladder, you get it taken out, right? So if you were to look at it just in a really simplified way, if you've got a diseased gut, right, you've got a part of your gut that's diseased and it's causing an illness that sort of drags into so many other consequences. Well, it would make sense to have intervention done for that if you thought about it this way. But like just general obesity, if you talk to a patient, and I do this every day, right, we perceive obesity as a personal responsibility, not as such an illness, right? So people are like, I'm going to start eating better and running more. I'm like, man, we're 100 pounds overweight, right? We can't run it off like this at this point. I mean, could you theoretically? I mean, yeah, at some point you could, but the amount of running you got to do to be able to accomplish that is just unreal.
Yeah.
But let me get back to your practice. So you've got the surgical side, obviously, and it seems like you're doing, super specialized stuff, and you're dealing with patients who need the more complex procedures. But you're also a board-certified obesity medicine physician. So tell me a little bit about that. What interventions do you all offer at the office? How do you sort of supplement your surgical side with those things?
Yeah. Well, as you know, that's like a separate part of training. It's something you actually have to, pursue after you're done with your medical diplomas and specialties. But the focus here is, what can you do to help people lose weight aside of surgery? Because surgery is the big gun stuff, but there's also room for medications. So I'll say up until the appearance of the GLP-1s, the new medications that everyone's talking about, excited about, those old medications, they are ineffective, a lot of side effects. You cannot keep taking it for that long. So it's just like, it's very archaic, it's very old. And these medications actually are so safe and simple that, people that don't even have the certifications are able to use. There's some considerations on it. We offer as part of a single approach for us to treat patients with obesity, or as a complement. So there's people that already had surgery, they need to lose more weight, and they can either have more surgery or just use medications, and that's great because it's just the bridge. Or people that have high end of disease of obesity and they're too sick to get surgery. We can have them lose some weight with the medications,
and then make them
and then they're healthier to actually withstand the surgery. At the end of the day, it's another tool in our arsenal. I am glad these medications are out because they have normalized a bit more the conversation about obesity. Now people, before, what happened with people interacting, like if someone said, hey, you need surgery for weight loss, they will get offended, right?
Yeah.
Because they say, you're calling me fat. That's the concept.
Yeah.
But now with the medications, people are like, they know you didn't have surgery because you came to work. You've been coming back to work, and they're like, what are you doing? Oh, I'm doing this medication. And then they're just saying, hey, try this medication, it's working for me. And and I think it's becoming more of an accepted thing to talk a little bit more about it. And I think people that end up losing some weight appreciate the impact. So I have patients that they have to lose 200 pounds, they lose maybe 20, 30, and they say, look, I've improved, but this is the end of that road. I think I do need surgery. And so it also changes people's mind, because they say,
get that done.
This is an improvement in my life. Let's go for to get the treatment that I need.
Sleeve gastrectomy is probably the most common procedure we all do. Tell me a little bit about the procedure, and then tell me what a patient experience looks like. So somebody comes in, they get a sleeve gastrectomy, in and out. What does that look like?
So in a short answer, so the sleeve, it's normally about 30 minutes procedure. People wake up, they're drinking, walking around. and the next day they're fine to go home.
Fantastic. Yeah.
Most people, you don't have to, but most people, they can go back to their desk job the day after they get discharged. That's up to them.
Yeah.
As long
and
as
their
they,
employer. Yeah.
But as long as they don't have to lift anything heavy for 4 weeks, just to make sure they don't develop a hernia at the incision sites, then they honestly they can do whatever they want with their lives. So the benefit of a sleeve is that it's the simplest. It has the least risk in terms of malnutrition because it's only limiting capacity, but not the way our GI tract handles the food and the nutrition. So the other benefit is that you don't have to worry about what medications you take because no alteration in the absorption, and also you're unlikely to harm your stomach, like with a bypass, for example. And most people is the most common bariatric procedure done in the States. People who don't have a bariatric fellowship training tend to do it because of its simplicity.
Sure.
But again, it comes back to knowing what to do when things go wrong, because even though there's less than 1% severe complication rates, which makes it as safe as getting your gallbladder removed. It's just people think it's like this extreme surgery.
Yeah.
If you do 1 million of them, you have 1%. You're gonna have a
very
1,000.
Very few,
but
absolutely.
So knowing what to do when things go wrong is the main key, and you just don't want to be taking care of someone who's just doing it. Also, in the sense of not taking care of patients long term. There's a concept that we call in the our jargon, which is leave it and leave it, in which the surgeon just focusing surgery and then no post-op care. You cannot get a hold of them. You basically have to change numbers so that they pick up the phone because So there's people out like that, and in reality, I think of things as if I operated on you, I see you as like my baby because you trusted me with your life literally, and my goal is to help you not only get the surgery, is to and to do well. It's not just you lost weight by have a good life, is continue to do well. Is there anything else going on that you need to
and I
help
think
with?
I've visited your office, and I think I can say that your office gives that impression because of the scope of what you all offer there. Because it doesn't look like a regular surgeon's office. I mean, you've got a kitchen in the middle of that office where people are taught how to cook, right? And that I love that. I saw that and I was like, part of what needs to happen with someone who suffered from, who has obesity is changing so many things about their lifestyle, right? Exercise being one, but nutrition being 99% of what needs to change. So of course we can modify gut tracts and we could do procedures, we could do shots, but there's people who are going to beat the shots, there are people who are going to beat the surgery, right? And they will gain that weight back. Happens with a lot of these bypassers, a lot happens with all sorts of weight loss shots. Being able to train them, educate them, and do it on the premises in the office, I think that's equipping the patient with the tools they need to be able to handle this and have the best outcome, which is what brought them to you in the first place. So absolutely, I feel like what you talked about, that's what we see reflected in your practice. So as a part of the scope of interventions, we talked about injectables as being a supplement to what you can offer. Surgeries, of course, for people who need it, the more complicated cases. On the diet side, on the lifestyle side, how do you offer, you offer guidance or education to patients, and how is that a part of your practice?
So it's so important, and it's such a cornerstone that we have a dietitian in our office.
Okay.
And every time someone comes in for a pre-op visit, a follow-up visit, they also see our dietitian at the same time. The interesting about nutrition and exercise is that if you use it on isolation, 98% of the people and the attempts to lose weight, they'll fail. But it's not because people are giving up or doing the wrong thing. It is because our body has the safety guardrails that basically meant for not allowing us to starve to death.
Yep.
So when our intention is to lose weight by limiting calories and doing exercise, our body interprets that as not enough energy to go around with and shuts down the metabolism, and then you cannot lose weight. So there's a biologic, genetic, hormonal background to it. That doesn't mean you shouldn't diet. Diet also helps you, and more than diet is eating healthy. You can be at the same weight and be healthier just by the type of food you take, and that can have also an impact in your life. Now, when you do surgery or medications for weight loss, the diet exercise component adds to that benefit.
Absolutely.
Also, you can hinder that benefit if you just do whatever.
Correct.
But
So
most people are very motivated. They wanna get the better results there. Whether it's the medication or surgery, they're committed to get better, and they tend to follow for the most part, our recommendations. But yeah, it's a very important topic.
So you've got a dietitian at the office that goes through education on nutrition to try and have them stick to something long term, right?
Yeah.
So I think what you meant with the diet was, generally speaking, for all physiological reasons, it's not worth it to diet for 2 months. I mean, you could diet, you'll see some results, and then you'll go back, right?
Right.
So the talk about diet is, well, changing what you eat long term, and the first step in that is getting education from someone who specializes in that to be able to find foods you're okay eating long term, right? Because I'm from South Asia. If somebody tells me to eat grilled chicken and veggies all day, I'll eat it for 5 days. Yeah, but then I'm gonna have to find things that I can enjoy, right? Same thing for Mexico, right? You have to find things that people can learn to incorporate into their diet and then be able to do that long term. So coming back to a little bit of a discussion on comparisons of the interventions, right? So you've got someone who goes out and takes Zepbound, wants to lose weight. Family's taken it, seen some phenomenal results. They're excessively overweight. They've got about 100 pounds to lose. They're 300 pounds, let's say, and their ideal body weight's around 200. Versus someone who goes out and does sleeve gastrectomy. What are we looking at in terms of outcomes? And then before you answer that, I'm going to say, what does it cost to a patient, give or take, to get a sleeve gastrectomy done? Because we know now the GLPs, for the most part, not covered by insurance for weight loss, and they're pretty expensive drugs, right? And they're not short term, so there's a cost to that as well. So if someone wants to compare the financial side of this, how do you compare those two, and how do you compare outcome?
Yeah. So both the surgery and the medication, they're lifelong commitments. It's just the surgery is kind of like one-time thing and you're done. Depending on the surgery, but let's say a sleeve is a bit under 10 grand. The medications, you have to take them for the rest of your life, because the tendency is once you stop taking it, there's weight regain. You don't have to be, that doesn't mean you have to be always on the highest dose, but
some level of maintenance.
But you do need to be on it. So if getting access is going to be a problem financially, because you're going to have, even if you have a copay, you're going to be paying for that for, if you're in your 30s, that's 30, 40, maybe even 50 years. I don't know. It's a long time to commit to getting a shot every week. So when it's worth it, it's worth it. When things started, it was like the Monjaro, which is the best one, $1,200 a month. It's, in less than a year, you had already paid for the surgery. Now it's getting cheaper. So, maybe let's just put a number, let's say $300, like super best scenario with coupons and whatever. I don't know, you have to do the math, but I don't know, in 10 years or 10 months, in 10 months is $3,000, I don't know, you just
in 10 years you paid for three sleeve gastrectomies.
And the important part is the way I see it is, will you lose weight with one of these medications regardless of your weight? Yes. But if you have a certain amount of excess weight, typically the classic number is BMI above 35, the surgery will be superior, meaning you will achieve your goals with surgery. With the medication, the way I see it is, you have a leak and you call a plumber, and the plumber does his thing, and you still have a leak, but instead of having a waterfall, you just have a constant drip. You don't go and say, "Thank you, sir, here's your money, go home." You say, "Come back. The job is not done." So with the medications, that's what happens. If you need the surgery, because that's what the excess amount of weight basically requires, the medication would just be a partial fix, an incomplete fix, and you're paying that for the rest of your life. Now, if you don't qualify for surgery or you're too sick for surgery, then sure, it's worth it because you will get better life expectancy, better life quality, and so on. But the question is it worth it? Not just financially, but the concept also. Is it worth me doing all this, taking all this problem of getting the medication, paying, injecting, and being,
having to deal
consistent
with that all day.
with it.
You have to the amount of physician follow-ups, lab follow-ups, so on and so forth.
Yeah.
And ever-changing costs and coverages and supplies. I mean, we ran into that issue with Ozempic at one point where the supplies went dry and people who had been on it couldn't get access to it. And that led to dramatic weight gains for people who lost substantial weight. So, I mean, there's always that uncertainty with long-drawn things, right? Versus a gastrectomy, like we talked about, you're in and out. The next day, you're back to work. If your boss is mean, and that's it. I mean, so that convenience and that idea of being done with it definitely sounds very enticing, especially for people who have excess obesity. They're not talking about 20 pounds to lose. We're talking about significant weight loss, which is also more likely to be achieved with these kind of procedures.
Right.
So, yeah, certainly. Anything new that's coming, in the world of bariatric interventions that excites you, that's up and coming?
In terms of surgeries per se, there's have been some endoscopic procedures that we're still waiting on results to see if they can be an alternative. Again, that's another option for people that are too sick to actually get full anesthesia and the length of the procedures. So that's a good option. For me, it's the more alternatives you have, the more tailored you can do management for patients because there's not going to be a one size fits everyone. And the other thing is the medications. So far the injectable versions of the medications everyone's familiar with, Ozempic, Wegovy, Mounjaro, Zepbound, they are right now the best ones. They're coming with pills. They're less effective, even though it's the same chemical and same component. But there is starting to be more research and more attempts to see if now we can do pills, for example, because it's more convenient to just pop a pill versus, I don't think it's that inconvenient to do a shot once a week.
Yeah.
But, you give people another alternative. And as technology gets better and we can, refine those formulas and so on and find more about different hormones,
absolutely,
I think that people will get more benefits. But right now, surgery is a superior method by far. It's just awesome that now we have a bridge between, those people that were in the middle of just overweight and type 1 obesity. And, it's like do exercise. We know it's not going to work, but do some exercise.
Yeah, you got some
gain weight so you qualify for surgery, and now there's actually options for those patients or people who already had surgery and they don't want something extra. And they can actually be brought down again.
What percentage of your patients do you think would require postoperatively like a commitment to some of these shots? Is there a good high percentage or is that fairly rare?
It's the minority.
Okay.
I would say the people I see failing weight loss surgery are the patients that have BMI typically above 50, so the most extreme end of obesity, and they had either a sleeve or a bypass. The reason why I'm saying that is there is a tendency of more resistance to lose weight with the more amount of excess weight the person has. So this is why, again, with medications, there's resistance, there's a limit. With surgery itself, there's also a limit. And I see a lot of my practice is seeing patients who fail to lose weight with surgery because I convert those surgeries into my other surgery that do not switch. And some of them, they can do well with medications, but that's another option that is sometimes not offered by other surgeons. But yeah, it's mostly kind of like an incomplete or insufficient treatment because they needed a bigger gun for their actual disease because it will come back. If you don't defeat obesity, it's like a cancer. You did the surgery, but you didn't do chemo, radiation.
Sure. Yeah.
So it's kind of like
gonna bite you back.
It's kind of like a way because you remove it, but based on the advancement of the disease, you needed to do more than just that. So basically, it's very similar. That's what happens.
It's like multi-stage interventions for folks that are so high on that spectrum that one thing may not be enough.
Exactly.
But if one thing were even to be close to being enough, it's not shots or pills. It's very likely to be surgery. Right? Some of these more complex procedures that allow you that dramatic weight transformation. I saw on your website it said you've done 4,000 plus surgeries, and now that you mentioned you started going to the OR at the age of 12, it makes sense because you look like a guy. So I was trying to figure out how did he get 4,000 surgeries, and he looks so young. So that now it makes sense. It looks like you got an early start. So tell me what keeps you busy outside of the OR, right? I know surgeons have this disease of loving the OR so much, where they're in there and they love their time there.
Yeah.
What do you like doing when you're out of the OR?
My main hobby is spending time with my son, my wife, hanging out with friends. Before I had a family, I was really into soccer and I used to play, and I even had a scholarship back in Mexico.
Oh, wow. Yeah. So see, I was part right when I said you're a professional soccer player.
You hit on the nail, yeah.
Yeah.
But yeah, I mean, I was, a frustrated dream.
Yeah.
It's... I kind of like gave it a shot to see if I could. There were like some doors that could be open, but I was like, no, I do think I want to do this. To me, I felt like it was like a more realistic pathway, let's say. God knows what it will happen. But I was okay. It wasn't like the best, so I was like aware of my skills. I thought I could do more as a surgeon helping people out. Yeah.
No, that's phenomenal. I'm gonna ask you some silly, quick, rapid fire questions, and the idea with this is you don't get to spend much time thinking about the answer. So the first thing that comes to your mind, just spit it out. Okay? I'm gonna start with a few questions. First question. This is pretty simple. Wegovy or Zepbound?
Zepbound.
Zepbound. All right. So Ronaldo or Messi?
Ronaldo.
All right. You're getting to 50, right? You get to 50 years old. Your wife sets up a dinner, right? You get to pick either Ronaldo or Chucky Lozano for dinner. Who do you pick?
Ronaldo.
Ronaldo.
Yeah.
All right. First thing you tell your patients post-operatively?
Kind of like everything went well. How are you doing? And then once everything is okay, tell them your only job is to walk, drink.
I would make sure they don't ghost you on the follow-ups, because I've heard stories where people get their surgery and that's it. They're gone, and then they see you back in 2 years.
Yeah.
So I would assume, I'm sure that's one thing you guys have to make sure you hit the nail on that one.
Mm-hmm.
All right. If bariatric surgery were a sport, what would it be?
Oh gosh, I do need to think about it.
Yeah, this is a tough one.
I don't know, skydiving.
Oh yeah, that sounds very risky. It sounds like it's got nothing to do with the hands. But yeah.
I'll say it's because there's the big drops.
Oh yeah, that's true.
I was thinking about that way.
I love it. All right, early morning surgeries or a late start?
Early.
All right, and if you were not a surgeon, what would you be?
Something in finance, probably.
Something in finance? Yeah. Okay, not a soccer player.
I mean, I would have tried, but I don't know if I would make it.
You wouldn't make it.
In real life, probably something in finance, yeah.
All right. And now, I know that recently with Methodist Hospital, which is kind of the structure where you're involved with, they've started a new GME program, and I'm aware that you're also involved with resident education. Is that something you like doing? Is that something you see a future in?
Yeah, I always like to be involved in educating. The way I think it is, when I was in training, I really appreciated the doctors, the surgeons who really put time, even if it's the extra minute or two, to just explain, this is why I'm doing this, versus just watch me and learn. That can make a difference. At the end of the day, we gotta teach people, because at some point they will be like, they will be doing my, I don't have my appendix, but they'll be taking my gallbladder out or whatever.
Yeah.
So if I've never taught
investing
them,
in your future.
yeah, it's I mean, for society, you gotta pass the torch anyway. And I enjoy it. So I was actually the chief educational resident in my training.
Awesome.
Putting lectures and conferences. I enjoyed. I enjoyed teaching. So yeah, I had it's a small program. It just started, and one of the residents, he's come with me, and I've shown him what to do. he's very appreciative because he sees that, you know, I'm showing him the ropes, and you know, it's very rewarding. It's you're helping people and helping people help people. So it's like the best. It's the best of all,
Love
you know,
it.
of all the world. Yeah.
Yeah, that's great. So for patients who are concerned about the safety, or like, you know, they're concerned about the risk of procedure, tell me a little bit about how safe these procedures are now, how comfortable you all are, you know, how sick or how well does a patient need to be to get through the surgery?
So we see health-wise patients from all the spectrum, from just having obesity and nothing else to, you know, having a significant organ disease. Everything is tailored to the patient, but in summary, the surgery is so safe that most people leave the next day, you know, on their own foot. Less than 1% of the most severe complication occurs in patients, which is a leak. Basically, wherever I cut or staple or saw doesn't heal well, and you have a perforation. We call that a leak because it was after surgery.
Sure.
That is the biggest risk, and it's actually the least likely. So it's great to have that as a combination of things. Most of downsides can be treated medically, you know, from failure to lose weight to reflux and so on. So if you think of other surgeries like a knee replacement, because a lot of these patients need a knee replacement or a hysterectomy and so on, because the complication rate is so low, it's somewhere between 20 to 50 times safer than some of those C-section, you know, some of those procedures that you hear people getting all the time. It is as comparable as getting your gallbladder removed. That's how safe it is. And you know how many people get their gallbladders out.
Everyone in their
it is the single most common surgery that I perform because, you know, there's so many gallbladders out there.
Yeah, and you mentioned people who are waiting to get organ transplantations. They need to lose weight. They need to be candidates. So you all do these surgeries on those people, and these are people with major organ failure. So even folks that are sick, you know, per se, can undergo these procedures and tolerate them and actually be in a better spot to be able to get these surgeries. You mentioned the knee, right? I mean, one of the biggest challenges if you talk to an orthopedic is like, well, lose the weight, I'll fix the knee, right? It's hard to lose that weight on a bad knee. So being able to go through a procedure like this, you get to a good weight, you're now a candidate for surgery. So that's phenomenal, and I feel like that adds so much option to these people where they've you know, they've got some other illness that needs addressing, but they wouldn't address it till their obesity is fixed. All right.
Yeah.
Perfect.
Yeah. I mean, I don't think there's a single specialty that would not see a benefit from their patient lose weight. So clearly, you know, from the medical aspect of diabetes, high blood pressure, orthopedic, just losing, so you can delay 1 or 2 years the need for total knee or hip replacement with weight loss.
Yeah.
So that's good because the hardware wears out and they need to be exchanged every 10 years. But if you have obesity, it runs out earlier and you gotta do it again and again. If you know, if you're just getting your 50s, maybe you need in 60s, 70s, and so on. Even psychiatry, there's decreased rates of depression, about 70%. That's like one of the least things that gets better. 70% improvement rate. That's a pretty good number.
Can't get it anywhere else. Fix a knee and get that result, right?
the most interestingly is like the one that's cured 100% of the time, because there's no 100% except for this thing. It's pseudotumor cerebri. So even neurology gets an improvement. So again, PCOS, you know, women are 50% more likely to have regular menses and 40% chance of losing their facial hair. So anything you can think of under the sun.
Anything excess weight touches.
Exactly.
This is something that sort of offers you an outlet.
And it's so underappreciated. It's crazy because we have normalized it. It's just normal. My hair is, hair is blonde versus black is, that's normal. I weigh the right amount of weight and my neighbor is 200 pounds above average and that's normal, right?
Well,
so it's common but not normal.
And I think the more awareness that comes around that, and I feel like if nothing else, the GLPs have sort of started that conversation. And I see this growing as these interventions grow, because we're going to have people that are not stage 1 obesity with no comorbidities. We're going to start to have people that have very high obesity because that rate's not slowing down. And no intervention touches obesity like surgical interventions do for long term. So there's going to be increasing scope, adaptation, and usage of these as things go along. So Dr. Medrano, I know where to find you if I want to send you a patient, but if someone's watching this and they want to see you for obesity, for surgery, for nutrition guidance, things like that, where do they find you?
So I'm located at the Landmark Hospital building at Presidio Parkway.
Perfect.
It's right at the intersection between 1604 and I-10 by the BMW dealership. So
love it.
Easy
Pretty
to
easy
find.
to find.
Yeah.
Yeah, absolutely. Well, this was so refreshing for me. I'm glad you were able to take out the time to come here. I really enjoyed this conversation, and I thank you for coming.
Yeah, thanks for having me. My pleasure.
All right, excellent.
Thank you so much.